Everyone, my name is Dr. Pradeep Shinoy from Pacespro. Today we'll be discussing about a few opportunistic infections and common conditions affecting the central nervous system in patients with HIV. So we'll start with the opportunistic infection. The most important opportunistic infection from exam point of view is cerebral toxoplasmosis. Again, it is commonly seen in those patients with advanced HIV disease. Usually the CD4 count is less than 200. It's basically a reactivation of the toxoplasma cyst. The infection would have occurred either in childhood or in adolescent, and the reactivation of the toxoplasma will lead to clinical manifestation. The patient can present with headache, seizures, or gradual onset focal neurological deficit such as monoparesis, hemiparesis, or patient can have gait disturbances. The key to diagnosis is identifying the features in the CT brain where we can see multiple ring enhancing lesion with surrounding edema. This is the key point when you diagnose a patient with cerebral toxoplasmosis. Remember, it's multiple and it's ring enhancing lesions. You can treat the toxoplasmosis by combination of sulfadiazine and pyrimethamine along with folinic acid for about 6 weeks. Remember, these are sulfa drugs and they can be associated with rash or nephrotoxicity. However, because it's a reactivation, patient needs to continue on prophylaxis with cotrimoxazole similar to the PCP prophylaxis. In those patients who are allergic to sulfa drugs, you can try clindamycin. Next most important infection which we see in HIV patient is Cryptococcus. Cryptococcus is widely disseminated in the soil. It's commonly seen in the bird feces droppings. It is transmitted by inhalation route. There are basically three forms. One is pulmonary form, meningitic form, and the disseminated form. What we see in HIV is the meningitic form, where the patient will have insidious onset headache. So it presents as subacute meningitis-like illness. The patient will have predominant headache and neck stiffness, maybe a low-grade fever, and the patient has raised intracranial pressure. They can come with cranial nerve palsy, and you investigate these patients with the cerebrospinal fluid analysis, which might show positive India ink, which you can see in this slide. The antigen test done on the blood may be positive, but that does not mean that patient has current infection. You can treat Cryptococcus by giving intravenous amphotericin B along with flucytosine or a prolonged course of fluconazole. Remember, again, this is an infection in immunocompromised individual, so the patient requires long-term antifungal prophylaxis. What about progressive multifocal leukoencephalopathy? It's again an opportunistic infection caused by the JC virus, which infects the oligodendrocyte, the supporting structure which forms the myelin. That's why you see a lot of white matter changes if you do an MRI. The patient here will complain with complaints of memory disturbances. There could be some mood changes or a progressive focal deficit such as monoparesis, or more importantly, difficulty in walking or gait disturbances. The MRI shows characteristic multiple bilateral T2 hyperintensities as you can see in this slide. The key differential is HIV encephalopathy. In HIV encephalopathy, the patient is in an advanced stage of HIV where patient has predominant memory symptoms rather than a focal neurological deficits. Treatment is that you have to initiate antiretroviral therapy. Now we're going to discuss about few of the antiretroviral therapies. There are about 5 groups of drugs which can be used to treat HIV. The first one is the entry inhibitor, also called as fusion inhibitor. The common example is enfuvirtide. Then we have NRTI, nucleoside reversible transcriptase inhibitors. They are tenofovir and adafovir and emtricitabine. Then we have non-nucleosidal reverse transcriptase inhibitors such as efavirenz or nevirapine. Then we have protease inhibitors such as ritonavir and darunavir. Then we have integrase inhibitors such as dolutegravir and raltegravir. Remember, we need to start ART as soon as the patient is been diagnosed. Remember, this is a deviation from the previous guideline. We showed that CD4 count is less than 350, then only we need to start ART. The current guideline says as soon as the patient is diagnosed with HIV, we need to offer ART. And PCP prophylaxis with cotrimoxazole should be offered when the CD4 count is less than 200. Normally, ART is a combination of 3 drugs, usually 2 NRTIs and another agent either from the protease inhibitor groups or an NNRTI group. What about post-exposure prophylaxis? It is given for incidental needle-stick injury for a healthcare worker. Although the risk is quite low, like 3 in 1000, we need to start them on group of ART along with follow-up HIV test at 3 months. The standard regimen is again a combination of 2 NRTI, that is the tenofovir and the emtricitabine, along with integrase inhibitors such as raltegravir for about 28 days. Once you start the patient on ART, the patient will have immunological responses, what is called as immune reconstitution inflammatory syndrome, also called as IRIS. Here the patient will have gradual progressive improvement in the immunity, which results in manifestation or worsening manifestation of opportunistic infection, most commonly tuberculosis. So the patient might have present with cough, dyspnea, enlarging lymph nodes or weight loss. So before starting ART, you need to screen these patients for opportunistic infection, most commonly tuberculosis. And if the patient is having tuberculosis, then you need to start them on anti-tubercular drug followed by antiretroviral therapy. However, if the patient has manifested with IRIS, you need to treat this with steroids. With this, we'll come to the end on this lecture series on HIV. Thank you.